Share screen. Hang on. Okay. Can you guys see the screen?
Yep.
Okay. Hey, sorry I'm late, but let's get started. I was just stuck holding a groin. But so we did half of the lecture last week. So now we're going to cover everything else that you don't really see regularly in your during your cardiology rotations or during your practice, but that get asked in the board. So it's going to be kind of a lot of information, but mostly bullet points. So when you prepare for your board, you don't have to waste a whole lot of time looking at all these things. So let's start with vascular medicine. So PVD. So this has been commonly asked in the boards. You should be able to distinguish claudication versus pseudoclaudication. Typically, true claudication, just like angina, it's a cramp, whatever pain they have, usually in the muscles, the calves or the thighs. Happens with walking a certain distance, you stop, it gets better, and it's fairly consistent. Pseudoclaudication, as you know, is secondary to neurological causes, usually some kind of spinal cord issue. It's more like numbness, tingling, ache. It has no correlation with how much you walk. It rather changes with your position. So it'll be typically someone who gets better as soon as they sit down, but not with standing and so forth. Very inconsistent. So they'll ask you what is the next test to do. If you think it's true claudication, you got to check ABI. That's the first thing. Pseudoclaudication is some kind of imaging to rule out neurological issue. So as always, if you have any questions, please ask me. Feel free to stop me here. So ABI criteria, again, something to know. Anything over 0.9 is normal. Less than 0.5 is severe. So these are the two big numbers to remember. The other important thing is if it's more than 1, it usually denotes a non-compressible vessel. So it's really not valid. Then you could do a TBI. This has been asked on the board several times. Toe brachial index rather than ankle brachial index. Or the other choice would be to do some kind of imaging, Doppler or a CT angiogram. So that's basically for diagnosis of PAD. Moving on. So stages of PAD, the only two important things to know are CLI and ALI and the criteria for chronic limb ischemia and acute limb ischemia. Chronic limb ischemia is basically loss of tissue loss, non-healing ulcer. That's chronic limb ischemia. Acute is a sudden painful cold leg. So anything that's like equivalent to a MI as ALI. So this is kind of the algorithm. I've highlighted the things you need to know in green. So if you suspect PAD, as we said before, the first thing is ABI. And then if that's more than 1, then you do TBI. Otherwise, if the ABI is normal, but they still have symptoms, then you should do an exercise ABI, because in borderline disease, you need to do the exercise first. And then for chronic PAD, the treatment is usually, the diagnostic would be ultrasound, and the treatment is exercise and medical therapy. All right. The key to remember is that ABI is diagnostic. You do not have to perform any other testing, including ultrasound, to diagnose PAD. Now, CLI, as I said, the 3 big things right up top right of the slide here: rest pain, non-healing ulcer, or gangrene. If you have any of these, you again start with ABI, and then you move on to imaging modalities quickly, like Doppler ultrasound or CTA, followed by invasive angiography. So just to recap, for diagnosis, you just need ABIs. But if you think it's CLI, then you need some imaging for both CLI and ALI. Imaging would start with ultrasound, and then followed by, as needed, you progress to an angiogram. So management of PAD, again, aggressive ASCVD risk reduction. So most of these people die from CAD, not from the PAD per se. So you want to make sure that you address all the risk factors, starting with smoking cessation. That's number 1. If they're symptomatic, you could do cilostazol. With silastazol, the important things to remember are two. One is CHF. It's contraindicated in CHF because it can worsen your volume overload. Two is that the biggest side effect is diarrhea. So if someone comes in with diarrhea, you stop the silastazol. About 50% improvement, 50% of patients improve their walking distance. That's a benefit with silastazol. The number two treatment, or rather the other important treatment, is supervised exercise program, just basically walking, and that helps. In terms of medical therapy, I don't know if they'll ask you in the boards, but this is a recent advancement. The last 3-4 years is Xarelto 2.5 BID. Improves your MACE, major adverse cardiac events in patients with PAD, as compared to aspirin 81. So they've been trying to push it. It's now a class 2A indication. So if it's one of the choices, it's for something for you to know. None of the other NOACs have been approved for this indication. So Xarelto is the only one, 2.5 BID. So the question would be someone who's has symptoms despite being on Xarelto and aspirin, and then they'll ask you, what more can you do to decrease the risk of a major adverse cardiac event or cardiovascular event? And then you choose Xarelto as a choice. That's the only place where you'll utilize this knowledge. Now, if they fail medical therapy and they're still symptomatic, then you can go to the angiogram and endovascular therapy to just improve their symptoms. It does not improve their survival or any other outcome.
Dr. Rasu, there was a question if this only applies to Xarelto or any other DOACs or NOACs.
Yeah, just for Xarelto, just for 2.5 BID. All right, because none of the others have been studied. So for board purposes, that's the only choice, Xarelto 2.5 BID. I know every other NOAC is also being studied for this indication, but none of them have a FDA approval yet. So maybe for this year, this is all you have to remember is Xarelto.
Thanks.
Yeah. So that was PAD and CLI. So acute limb ischemia. Now this is a life-threatening emergency. The diagnosis is anything symptoms less than 2 weeks. The 6 P's of pain, pallor, paresthesias, no pulse, or pulseless. They cannot move, paralysis, and temperature change. So poikilothermia. So any of these, it's pretty apparent. If this happens, it's a surgical emergency. They need to have immediate vascular surgery, consultation, angiogram, and so forth. Now, the cause of death, mortality 20% at 1 year, and the cause of death is usually cardiovascular. So when you see them, actually, they'll say, what's the first thing you do? First thing you do is a heparin drip. So you start anticoagulation, then you call vascular to have the invasive angiogram and intervention. And if any of these patients get readmitted, the commonest cause is reocclusion and compartment syndrome, because there's so much inflammation there that many of these folks end up with compartment syndrome that needs surgical intervention. So keep that in mind. So the other points to remember here, ABI correlates with survival. So ABI is diagnostic, but a poor ABI correlates with poor survival. Now, most of these patients with PVD or PAD also have CAD, carotid, and renal disease. The incidence is roughly about 50%. And even without any pre-existing obvious symptomatic cardiac disease or diagnosis, they have a 5% MACE rate per year. So these are kind of something to keep at the back of your mind. I'm not sure they'll test you on these particular numbers, but just remember half of them have coexistent carotid disease, CAD and or carotid and renal disease. So that was PAD. Moving on to aneurysms. Let's see. So acute aortic syndromes, primarily dissection. As you know, type A is surgery and type B is conservative. Do you guys all know the distinction between type A and type B? You can put it in the chat box here. What is type A and what's type B, the diagnostic criteria? So type A, as you know, if it involves the ascending aorta. So type B, anything beyond the subclavian artery. So ascending and the arch would be type A. Anything beyond the subclavian would be type B, basically the descending. So type A usually means surgery. It's emergent surgery. Type B is conservative therapy. The other acute aortic syndromes include, of course, aneurysm rupture, that's surgery, A penetrating ulcer and intramural hematomas, you'd often find this in CT scan reports. Those you treat conservatively, no matter what the size or how big they are. There's no surgical indication of these. So how do you diagnose these? For dissections, asymmetric blood pressure, you could see often has aortic insufficiency, and they can also have a pulsus paradoxus. So typical presentation would be a patient coming in with acute chest pain, asymmetric blood pressure, can have a pulsus, chest X-ray shows wide and mediastinum. Then they'll ask you, what is the next test to do? So typically the next test would be a CT scan of the chest, followed by surgical consultation. What you don't do is give them heparin, TPA, anything like that, because if the dissection involves the coronaries, they can also have ST elevation. So there's been I think a question in one of the a few years ago where they had a presentation something like this, but the EKG also showed STEMI, and the choice was TPA, and so forth. So typically TPA is not a choice in most circumstances, unless you have a more than a 2-hour travel time to a cath lab. So keep that in mind. Oftentimes when you're answering these questions, it's more of like eliminating the choices rather than knowing what the exact choice is. So in terms of imaging, TE is as good. You do a TE if it is easily available, and especially if there's CKD and your diagnostic suspicion is not very high, then you do a TE. Otherwise, CTA is a go-to modality because it's much quicker. TE also takes a little bit longer time to get set up and do it, and also it's more stressful for the patient because it can be uncomfortable. So the blood pressure can go up, and that can worsen your dissection. That's the reason we don't always jump to a TE. So thoracic artery aneurysms, the key here is first is diagnosis, more than 50% of the expected dimension. The second is basically the surveillance criteria. So you can ignore most of everything else in the slide. Let me just tell you what the screening and surveillance. Annual surveillance up to 4.4 centimeters, beyond 4.5 and above, it's 6 monthly for the ascending aorta. For the descending, we're a little less stringent, up to 4 to 5 in the 4 to 5 centimeters, it's once a year, and beyond 5, it's 6 monthly. Remember that can be tested. Now, how do you treat for this is basically for dissections. You control your blood pressure. Type A is emergent surgery. Type B, just medical therapy. That's all you need to know. But if someone with a chronic type B dissection presents with back pain, then that's an emergency, because back pain basically points to rapid expansion of the aneurysm and potential rupture. So then you get a surgical consultation on them. So when do you operate? If it's not an emergency, 5.5 centimeters is what you need to remember for both thoracic and abdominal aneurysms. Now, high surgical risk, they're not going to test this on your exam, so just ignore that. The only caveat being, if the patient is undergoing bypass for some other reason, then the number is 4.5. And it's also 4.5 for people with Marfan syndrome, especially in women who want to become pregnant. If they're more than 4.5, then you first fix that before they become pregnant. Now, for descending aneurysms, they can also fix it percutaneously, just like EVAR for abdomen. You have TVAR for descending aortas. I don't think they'll test you, but the key numbers to remember from this slide is 5.5 for the aneurysms and 4.5 if they have Marfan's or Marfan's plus pregnancy. Now, moving on to AAA, it's again very similar to thoracic aneurysms. It's once a year for 4 to 4.5 centimeters, and more than 5 centimeters, it's 6 monthly. Less than 4, it's 3 years, but they have taken that out of the guidelines, so I don't think they'll quiz you on that. Just remember 4 to 5 is once a year, more than 5 is every 6 months, and then you operate at 5.5. You could do surveillance with either ultrasound or CTA. For thoracic, it's only CTA, but for abdomen, you could also use ultrasound. And this table is just for your knowledge. It tells you how we came about with this 5.5 centimeter magic number. You can see that, less than 5, the annual rupture risk is very low. Just about 0.5 to 1%. In some studies, it's up to 4 or 5. But once you go beyond 5.5, your risk really jumps up quite a bit. I know this gives you a wide range, but it's really 3 to 5%, up to 5.5%, and then it goes to 10 to 20% range beyond that, and it goes up exponentially, which is why you choose 5.5 as the cutoff to operate. So we talked about this. The treatment, the other thing is it's either 5.5 or a 0.5 millimeter or 5 millimeter growth in a 6-month period. So you need, if they're growing rapidly, then you operate. And just like with CABG and thoracic, if you need to fix PAD, sometimes they have a stenosis right below the aneurysmal segment, then you have to fix the aneurysm as well. You don't have a choice. So you do that. So what is the choice for abdomen? EVAR is the first choice. So you need to know the benefits of EVAR. It's short-term, much lower mortality and morbidity short-term, but at 5 and 10 years, there's no difference between EVAR and open repair. So that's something to keep at the back of your mind. And EVAR does have a higher risk of re-interventions after 1 year. So once you have surgery, you're good to go for the rest of your life. But with EVAR, you have, the graft fails. Basically, it starts leaking around the seams, and you might have to go and redo it. But it's still the first choice. So moving on to carotid disease. So the first question is, when do you order a Doppler? So if someone has symptoms or you hear a bruit, you order a Doppler. If you don't have any for routine screening, it's very specific indication. Men aged 65 to 75 with a history of smoking. Those are the only people who will order a screening carotid without any other indication for it. You don't order it in women. You don't order it in anybody less than age 65 or over 75. Now, when you do that and you do find a significant stenosis, which is more than 50%, then you're entitled to order an annual follow-up ultrasound. All right, so going over it again, age 65 to 75 with a smoking history in men, or you need to have other recent symptoms of BRIE to order a screening Doppler. So what do you do if they have disease? Now, this is new. In asymptomatic, previously, until about 2-3 years ago, we never did anything in asymptomatic people. But the guidelines have changed recently, so they can quiz you on this. If they're over 60% and they're considered lower surgical risk, which is less than 3% risk, then these people get a carotid endarterectomy. Anybody symptomatic over 50%, you get surgery. The other thing that's changed is that now they recommend early surgery within 14 days after a stroke. Previously, it used to be 6 weeks to 3 months. Now, within 14 days, they recommend surgery for anybody who's had a stroke from ipsilateral carotid artery. Now, if someone is high surgical risk because of other risk factors, then they recommend a stent. It's class 2B indication. So class 1 is still surgery, 2B is stent. So the other reasons which you should be aware of, I don't know if they'll necessarily test you on this. So if someone has an occluded carotid, and then you operate on the other if it's more than 50%, whether they have symptoms or not. All right. And now if they have a CTO, you do not operate. Or if they've had a massive disabling stroke, then there's no reason to operate if it's not going to make a difference to their outcomes. So if you have someone who has severe stroke, who's basically, vegetative state in the ICU, something like that, then you don't operate on them. All right. So moving on, Buerger's disease, typically, we rarely see them, but they always ask, it shows up in the boards every few years. Typical patient would be a young male smoker. Buerger's disease is a disease of smokers. And it presents with foot claudication, opposed to calf or thighs and PAD. So if someone has pain in their foot with walking, think Buerger's disease. These folks develop venous thrombosis as opposed to arterial thrombosis and PAD. And they can also have upper extremity involvement. So young smoker with upper extremity involvement with ulcers or vascular insufficiency symptoms or foot claudication, think Buerger's disease. And the treatment for this is smoking cessation. Now, fibromuscular dysplasia, think young female with hypertension. And you'll probably get an image like this. There's a little beaded appearance. This is a renal artery, and you can see the beaded appearance here. This is classic fibromuscular dysplasia. Most of them have renal involvement. Some of them can have this cerebrovascular as well. So it's a string of beads angiogram. The treatment is just balloon angioplasty, no stent, and usually they do well in vessels that are accessible to balloon angioplasty. So intracranial don't do too well, but renal do well. So someone with difficult to treat young female with hypertension, nuanced or difficult to treat, think FMD. And just remember this image. If you see this, FMD, balloon angioplasty is a treatment. So moving on to DVT. Did you guys cover DVT with hematology or any other, anybody else?
I'm trying to remember. I think maybe slightly with heme, but
Okay. So I can skip these. I think these are, so just a couple of points here. You don't need to know Wells criteria. Just remember, if the pretest probability is low, then you do a D dimer. If it is not low, you start with ultrasound. But the key here is, if you suspect DVT, then you start heparin before you do any imaging. So it's always, the exam will always ask you, what is the next step? What's the, you see someone with a painful leg, they had a knee injury playing basketball, now they're in the ER, what is the next step? So it's always start heparin first before you do any imaging. So you don't need to know this. So treatment for DVT, you know all that. The things to, a couple of things to remember here. HIT always shows up in the boards. Just remember, it's a 5% hit, risk of hit with UFH, less with low molecular weight. Now, if you have HIT, you cannot use low inox. Just remember that. Now, fondaparinux is probably the best one to use for outpatient long-term therapy because there's no monitoring, no risk of hit. We use that at the VA quite a bit. So DVT in pregnancy, that shows up as well. You don't start warfarin typically, you just do fixed dose outpatient unfractionated heparin therapy. This has shown up in the boards a few times. Just remember that, just unfractionated fixed dose heparin, full UFH, not low inox. So how long do you treat with warfarin? Transient cost, if you know there was a cost there, then 3 months. Lifelong is only for people with homozygous thrombophilia syndromes or recurrent DVTs after a second DVT. Right. So let's move on with these. So anticoagulation in pregnancy. So this is typically someone with a mechanical valve, that female who gets pregnant. So this is kind of, you don't, this is just for FYI information, basically. The current recommendation is that you continue warfarin. You just stop it 2 weeks before anticipated delivery to prevent fetal injury or intracranial hemorrhage. Otherwise, you try to continue warfarin throughout. Now, the only caveat is the dose of warfarin, but I don't think you need to know that for internal medicine boards. And typically they say, if you use less than 5 milligrams of warfarin, that's last table here on the right side for mechanical valve prosthesis. In general, less than 5 milligrams does not cause fetotoxicity or is not teratogenic. So you continue that. If you need more, this is for the initial part of the pregnancy in the first trimester. If you require more than 5 milligrams in the first trimester, they ask you to shift to unfractionated heparin and then go back to warfarin in the second trimester and the third trimester. And then you stop it after about 37 weeks. So just remember, less than 5 milligrams, you continue, nothing to do. If they require more than 5 milligrams of warfarin, then stop it for the first trimester, put them on heparin, unfractionated, fixed dose. And then from 12 weeks onwards, second trimester, you could go back to warfarin. So this can be a board question. You should know this. So moving on to the actual cardiac issues here. CHF, you guys all know all this pretty well. So I'm just going to touch on the bullet points, so to say. A lot of this is, I'm going to skip a few of the slides. So you should know this. Classification, this is ACC classification. Stage A is at risk of heart failure. B, so risk of heart failure would be risk factors, basically hypertension, diabetes, metabolic syndrome, and so forth. Stage B, you have structural heart disease. So it could be LVH, some kind of valvular dysfunction, or even cardiomyopathy, but no clinical symptoms of heart failure. Stage C, you have symptomatic CHF, and stage D, you have rest symptoms despite maximal therapy. So they could ask a question where they describe a patient's condition, and then they ask you to choose what stage it is. Now, NYHA is very similar. One, structural heart disease, no symptoms. So this will be equivalent to stage B. Two is you have mild symptoms, but less than 50% limitation of activity. Stage 3 is marked symptoms, comfortable only at rest. So it's more than 50% limitation of activity. 4 is symptoms at rest. So know the stages of heart failure. So BNP, they haven't asked in a while, so I'm skipping that slide. You do need to know what some of these systemic diseases associated with cardiomyopathy. This has been asked in the past, especially thyrotoxicosis can cause cardiomyopathy, primarily from a high volume, high flow state, high cardiac output heart failure. You should know that. HIV can also cause cardiomyopathy without any other manifestation, any other cardiac manifestation. Infiltrative diseases, especially amyloidosis, Charcot, hemochromatosis shows up. I've never seen a case, but it's shown up in the boards. So they'll give you some other issues as well. Diabetes, typically bronze diabetes, heart failure, high hematocrit, and so forth. So just be aware of that. And pheochromocytoma can also cause dilated heart failure, cardiomyopathy. So causes of decompensation, the question would be a patient who's doing well, no issues, and then he comes with decompensated failure to the ER. So what do you look for? Number one is non-compliance, increased salt intake. Number two is NSAIDs, then followed by other usual suspects, some other concomitant infections such as pneumonia, UTI are the big ones, atrial fibrillation or arrhythmia, followed by anemia, and then uncontrolled or poor hypertension, renal failure, and so forth. Ischemia is right at the bottom of that list. If they have chest discomfort, any signs of ischemia, you need to work up for that. But typically, for board purposes, one of these medications would be the culprit. So how do you treat? You all know everything, but just going on. So the things to remember for NYHA1, the two medications are ACE inhibitors, beta blockers. Now, lifestyle changes for everybody. So when you move to NYHA2, then you have Entresto. It's class 1 indication that can clearly be tested on because it's a recent drug and it's a recent development. Now, class 3 and 4, you have spironolactone. The key to remember with spironolactone is hyperkalemia. So when it came on, everybody started prescribing spironolactone, and 5 years later, the data showed increased mortality in these patients. Even though in the initial RALS trial, there was a 35% mortality benefit, the actual real-world data was exactly opposite to that, and primary reason was hyperkalemia. We were not being very careful with that. So when you see spironolactone anywhere in the question, think hyperkalemia. It is class 1. It does have a mortality benefit, but you have to be careful. So these are the primary medical medications to use for long-term benefit. Symptomatic relief would be primarily diuretics, loop diuretics. Sometimes you add spironolactone to it to improve hyperkalemia. Now, the newest addition to this is Jardiance. It's for class 1 for anybody with heart failure, irrespective of the NYHA category or symptoms, whatnot. But it's fairly new. I'm not sure if it will be in the boards this year. Usually it takes them about 2-3 years to catch up with these guidelines, but that's something to know. So the question here would be someone who's on all the medications, then they'll ask, what else can you do to improve their long-term outcome? So we talked about this. This is basically telling you class 1 is ACE inhibitor as well as ARB. And then in patients with 2 or 3, class ARNI is class 1 again. So the other drugs you should know with respect to heart failure, which are the bad ones? The non-dihydropyridine calcium channel blockers, diltiazem, verapamil, they're contraindicated, especially in EF less than 40%. So typically you'll have someone with AFib, also has heart failure, keeps coming with decompensation, then you try to take their diltiazem off and put them on something else for rate control. Amlodipine is okay to use, so it does cause some leg swelling, but you can, it's not a contraindication. Other drug to know is digoxin. We don't use it much. We used to use it a lot until about 10 years ago. The only benefit is it reduces hospitalization. It does not have any mortality benefit. It can be tested on that. Know that. Hydralazine and nitrates was probably only drug studied in just one particular race. So there was a study done in African Americans called the AHEF study, which showed benefit, significant benefit. Now, as you know, the ACE inhibitors have been primarily studied in the Caucasian population. So in Asians and in the rest of the world, it is not as beneficial. So they were looking for alternatives, and especially in African Americans, it does not carry much benefit, even in the large initial trials. So in these folks, you could use hydralazine nitrates, even though it's class 1 is still ACE inhibitor, but if they have renal dysfunction or for whatever reason they cannot tolerate ACE, then you could definitely do hydralazine and nitrates. Other thing to know, do not combine ACE and ARB because it worsens cardiac outcomes. It also worsens renal outcomes. It can have AKI as well as worsen heart failure. We talked about spironolactone. The other drug to know is ivabradine or Corlenor. It decreases heart rate. It doesn't have much of the clinical benefits. So the only time you would use this is someone who's tachycardic, has recurrent heart failure, and is not able to tolerate any of the other medications because of a low blood pressure. So they have soft BP tachycardia. You could try ivabradine to slow them down, and maybe that'll help with your heart failure. So which are the medications which make you live longer? So survival prolonging drugs, you really need to know this. 3 of them: beta blocker, ACE inhibitor, and spironolactone. Now, isosorbide and hydralazine in African Americans. Now, the other drug that's not here that I should put in is ARNI, sacubitril valsartan. It is also shown to improve survival in patients with heart failure. Things that do not prolong survival: digoxin, diuretics primarily, and those that can cause harm: non-diatropic and calcium channel blockers. Most antiarrhythmics worsen survival in these patients, including flecainide and sotalol. Amiodarone helps. And chronic outpatient vasopressor therapy, we used to do this in the past: dopamine and dobutamine infusion outpatient. Those things also worsen survival. That's why we stopped doing them. When you use AICD, just the only number to remember is 35%. EF of less than 35%, you do prophylactic ICD. Now, biventricular pacing gives you symptomatic relief, and the ICD part is what gives you survival benefit. The pacing per se does not increase survival, but it does decrease the symptoms. So if you have, this would be a patient with a left bundle branch block on the EKG who's on maximal therapy, but yet is not doing well, keeps coming into the ER. So what is the next thing you can do? That would be biventricular pacing. It works best with a wide QRS, especially left bundle branch, but it can be used in any wide QRS, even a right bundle. So peripartum cardiomyopathy, we don't see it very much, but it's important to know. It shows up in the boards every few years. So basically, it's defined as LV dysfunction during pregnancy or up to 6 months in the postpartum period. Most patients do recover, though about 13% have persistent cardiomyopathy. It takes up to 6 months to recover. The other thing to remember here is the risk of recurrence, because that's a question they'll ask you. Someone has had peripartum cardiomyopathy, they want to get pregnant again. What is your recommendations going to be? If they've completely back to normal, they still have a 25% chance of recurrence. If they're not fully recovered, they have a 50% chance of worsening. So those are the numbers to remember. And if they do want to become pregnant, then you'll have to stop the ACE inhibitors. You can continue the beta blockers. So, but no ACE inhibitors or sacubitril or Entresto. Okay. So moving on to arrhythmias. So almost every year, there's at least 1 or 2 questions on syncope and atrial fibrillation. And most of the time, if you ask to pick a next test, if someone comes with any kind of either syncope or rapid heart rate, palpitations, your first test should be an EKG, because you all often forget that if there's no EKG provided in the question, that's the first thing you do, a 12-lead EKG. And then you followed by Holter monitor. So never choose EP study. It's never done, for at least internal medicine board purposes, you'll almost never choose EP study as the answer. And the first thought process here, first ask yourself, are they symptomatic or not? If they're not symptomatic, then you rarely ever have to do much. And the second thing is that it's a reversible cause for whatever they're coming in with. So tachybrady syndrome, remember the heart rate has to be both over 100 and less than 40 to qualify as tachybrady syndrome. If they do have that, then they qualify for a pacemaker. So typically, you need to be able to, if they provide a symptom rhythm correlation in the question stem, then they qualify for a pacemaker. If they do not have a symptom rhythm correlation, then they usually don't need a pacemaker. So moving on to heart block, things to remember here: first degree block, always benign, nothing to do. Second degree, if it's Venki block, nothing to do. That would be type 1. But type 2 or AV dissociation, they require a pacemaker for board purposes almost always. Though in theory, they have to be symptomatic for this to require a pacer. But or have certain other characteristics. But for internal medicine board, if you see high-grade AV dissociation, think pacemaker. If they have alternate bundle branch block, again, think pacemaker. As long as they don't have any reversible causes, primarily electrolyte abnormalities. Now, sleep apnea is also a cause. They have someone with sleep apnea during a sleep study, they present with AV block, then you do not do a pacemaker, you treat the sleep apnea. The other tip to remember, neuromuscular disorders, any kind of muscular dystrophy with any AV block equal spacer, because these people can progress rapidly. So anything other than type 1, even if they don't have any symptoms, but you do see a higher than a Mobitz 1 or first degree, then think pacemaker. We just went over this. So this is the list of all the SVTs that you need to be aware of and what to do with them. So atrial tachycardia, ablation, class 1 indication, rate control ablation, all AV and RTs, again, you ablate them. If you have any accessory pathways, you ablate them, like WPW syndrome. But you should also know that you could do a vagal maneuver, and that can break if you see them acutely presenting with SVT, you should always try to do a vagal maneuver first and see if you can break the arrhythmia. Multifocal atrial tachycardia, the typical patient here would be someone who's has bad COPD. They'll show you a EKG with irregular rhythm, but you'll see good P wave activity there. The treatment for this is beta blockers. They do not need any anticoagulation. But the big ones, the commonest ones are flutter and fib. Both of them need anticoagulation. With flutter, you try to ablate them. That's the class 1 indication. With fib, you treat them with medications. You only ablate if they fail medications. Right. So this, I don't think you need to know this. I'm going to skip the slide. This is basically all the congenital syndromes. I don't think they're going to ask you quiz you on that. So this you should know. This is the nomenclature for atrial fibrillation. So now we have paroxysmal, persistent, and chronic. So what's the difference? Paroxysmal atrial fibrillation is more than one episode, more than 30 seconds, but resolves spontaneously without any antiarrhythmic therapy or without giving them a shock. So beta blockers, cardism does not count. So within 7 days, it terminates. Even with maybe a cardism or some rate control agent, that would still qualify as paroxysmal AFib. Persistent is it lasts more than 7 days, or it requires cardioversion, either electrical or pharmacological. That's considered persistent. Chronic AFib is basically your treatment goal. You've given up on this patient. You just want them to be in rate control and anticoagulation. You're not going to try to cardiovert them. Then that's considered chronic AFib. So remember, less than 7 days is paroxysmal without any treatment. More than 7 days, or if you need to treat, it's persistent. So how do you manage AFib? So rate control, you all know the medications. Digoxin also helps. So does amio. For rhythm control, you basically have two main medications, sotalol and ticozin. Dronadrone used to be, dronadrone and amiodarone are also available, but they cause a significant amount of toxicity, so you rarely ever choose them. Those are the big ones, class 3, and class 1 agents are flecainide and propafenone. So basically, you have 3 drugs, sotalol, ticozin, and flecainide as your mainstays for AFib medication management of AFib. So the question here to ask would be, what do you follow in these patients? So in sotalol, it can trigger CHF. So remember that, and you follow the QTC. If the QTC prolongs more than 10%, you stop it. Otherwise, they end up with polymorphic VT. Same thing with ticozin. With flecainide, class 1C agents, you follow the QRS duration. So remember that class 1 is QRS, class 3 is QTC. So anticoagulation, again, you all know this. You need to know CHADS-VAS score, how that's calculated. So they'll give you a patient and you have to decide whether this person requires anticoagulation or not. Typically, if the CHADS-VAS is 0, then you don't anticoagulate. If it's 2 or more, you anticoagulate. They're not going to give you a CHADS of 1. Be familiar with the Has blood hemorrhages scores. You don't need to know what constitutes them. I think most of the time the patient would very obviously be high risk of bleeding. This is someone who's had recurrent bleeding, has, let's say, portal hypertension or something, and AFib. In those folks, you don't want to do warfarin, but you should consider the Watchman device in these people. As you know, Watchman device is also called as left atrial appendage occluder. There's another one that's come in the market as well. These are people who have an indication for anticoagulation, but are at high risk either because of bleeding or frequent falls. So these are the folks who can be referred for a mechanical closure of the appendage. Now, other thing to remember, cryptogenic CVA, especially in young patients, they get a loop recorder if they don't, to rule out PAF, because in one of the pivotal studies done by neurology, there was a 30% incidence of paroxysmal AFib in patients with cryptogenic CVA when they monitored them for a year with the loop recorder. So that's the reason we do that now. So this is the standard dosing of anticoagulants, because sometimes they give you multiple choices on how to anticoagulate these patients with more than one NOAC, so you need to know the doses. So rivaroxaban is the only one with a single dose, once a day dosing. So is actually doxaban as well, which we don't use at the VA. And dabigatran and apixaban are twice daily dosing. Now, apixaban has the least adverse cardiac events. So in anybody with CAD, we tend to use apixaban. You should also know the doses for people with renal failure or old age. So both of them have apixaban and rivaroxaban have lower dosing for them, 2.5 apixaban and 15 a day for rivaroxaban. Usually age over 80 or creatinine over 1.5 and creatinine over 1.5 rather. So you have to have both criteria for that dosing. Dabigatran, we don't use much at all because it has it was the first one to come on the market, but it also has a higher risk of bleeding complications. So it's relatively contraindicated in over age 75. So moving on, we can skip the slide. That's a chat score. We can slip that. So WPW, so EKG shows up. So know the EKG. I have it. I'll show it to you later on. A couple of things to remember. If they don't have any symptoms, they just have a little evidence of WPW on EKG, you don't have to do anything. If they are symptomatic, then you ablate them. All right, but if they come to the ER with tachycardia, then you try vagal maneuver, or you could do amio or adenosine or amiodarone. If it's chronic WPW where they're coming to you with a history of going back and forth, then you can treat them with a beta blocker or a calcium channel blocker as well. All right. So one other thing to remember is, I think one year there was a question with a pilot, a commercial pilot coming in, and he has WPW on the EKG, but completely asymptomatic. So in these are considered high risk occupations. So you treat them even if they're not symptomatic, you ablate them. So ablation is definitive management. So that's what you do in people with high risk occupations. So the whole reason for me to show you this slide is what happens in AFib. So A is where there's it's normal sinus rhythm. It goes down the sinus or the accessory pathway, which is fast conducting, and comes back to the AV node. It sets up a cycle going fast. Now, when you have atrial fibrillation, it's so chaotic there that all these keep hitting the accessory pathway, but because of the chaotic transmission, it really cannot set up a good cycle. So it's fast, but not terrible. But if you organize it by giving them any of these medications like a beta blocker or anything that decreases the conduction, then it becomes more organized and goes really fast. That's the reason you don't treat these people with calcium channel blockers or beta blockers when they're going fast, because that can cause VFib and arrest. So that's why you do either AFib and WPW. If you get an EKG and they want to know what you do next, answer is either amiodarone or a shock. No other medical therapy. So ventricular arrhythmia, couple of things to remember. Artifact. You often get an EKG where you think it's VT, but it's really artifact. So watch out for that. If someone is stable, just gets a routine EKG, looks like VT, it's probably not. And the other thing to distinguish is SVT with aberration versus VT. The thing to remember here is almost 90% of white complex tachycardias are going to be VT. So, and if someone has a history of CAD, then it's even higher percentage. So if you're not sure if it's VT or SVT, then err on the side of calling it VT. And on the physical exam, if they use terms like Canon A waves, a variable S1, variable blood pressure, that all points towards VT. Okay. So PVCs, again, common question. Someone comes with some occasional palpitation, EKG shows PVCs. All you do is reassurance. You can do beta blockers for symptom relief. Now, the only indication, again, I don't know if they'll ask you in internal medicine, but if they have a 30% or more PVC load, then you can ablate it. But for your board purposes, it's usually reassurance and maybe atenolol. So antidiuretic therapy, antiarrhythmic therapy rather, I'm not sure how much you need to know, but just this flecainide, as I said, class 1 agents, QRS gets prolonged. So you got to watch that on the EKG. And class 3 QTC gets prolonged. So that's what you follow. More than 10%, you stop it. So CAS trial, I don't think they've asked in a long time. This was some in the late 90s, early 2000s. So before the CAS trial, we actually used to use flecainide and sotalol to suppress PVCs in patients. Just for the heck of it. They come have a few PVCs, have symptoms, you put on flecainide. CAS trial showed like a 30% increased mortality with that approach. So since then, we stopped using these drugs. So that's a landmark trial. So that's something to be aware of. So amiodarone, I need to know all the toxicities of amiodarone. There was a question one year where they said, which of these is not a toxicity associated with amio? So you need to know. The big ones are lung and thyroid. It can also cause liver toxicity, skin discoloration, and photosensitivity. Someone is on amio and has sunburns, and they need to have good barriers and sunscreen and so forth. It can also cause a reversible corneal discoloration. So all these patients need annual DLCO, TSH, LFTs, and ophthalmology annual eye visit to look for corneal discoloration. And amio also interacts with a number of medications like Coumadin. There's a whole bunch of it. So if there's a question of drug interactions, amio is a culprit usually. We went over indication of ASCD. I'm going to move on. So syncope. So this is again common in the boards. So you need to know the basics. So if you have anything on syncope, question about syncope, think history. History is diagnostic in 80%. That's where the bang for the buck is. Get a good history and physical. Most of them are benign or neurocardiogenic or vasovagal. Occasionally they're neurological, but it's not gonna. It's rarely ever neurological deficit causing CVA. It has to be a major CVA. So if someone is passing out from a neurological cause of syncope, then they're in a bad shape. So the whole goal of syncope is to kind of figure out if it's a serious underlying cause or not. If there's a true cardiac reason for the syncope, it can be serious. So you basically, the whole workup is to first make sure that it's syncope, it's not seizure. And then the second goal is to make sure there's not a serious cardiac cause associated with it. So this is a good slide to understand syncope. So right in the middle, the cause of syncope always is global cerebral hypoperfusion. So not enough blood in the brain, usually due to low blood pressure, people pass out. So there are two causes for that, either low cardiac output or low peripheral vascular resistance. So all the veins and arterioles have expanded, all the blood is pooling there, there's nothing really circulating, or low cardiac output. And then if you look at the next circle here, the reason for low peripheral vascular resistance is typically a structural damage, usually autonomic nervous system damage and spinal cord injury patients and things like that. Or you have inappropriate reflex. So that's a vagal mediated cause. And low cardiac output is usually either cardiogenic shock or inadequate venous returns because of low volume. Right, either volume depletion or venous pooling from neurocardiogenic neurological causes. And low cardiac output is either structural from CHF or arrhythmias like AFib, rapid ventricular response. Inappropriate vagal reflex is either vasodepressor, which basically enlarges all the arterioles, or it's cardioinhibitory, which means the heart rate is very low. So it's either bradycardia or a low blood pressure there. And low peripheral vascular resistance, either from drug-induced autonomic nervous dysfunction, usually seen in Parkinsonian medications, a lot of psych meds, or it could be structural damage from trauma or neurodegenerative diseases. So syncope, think low blood pressure, and usual cause is either medications, which cause peripheral vasodilation, including like drugs like hydralazine, trazodone, and so forth, or a vasovagal response with low blood pressure, as well as low heart rate, bradycardia, or structural heart disease such as arrhythmia VT. So the whole goal of your workup is to make sure it's not one of these things. It's not arrhythmia or severe structural heart disease. So you do an echo, you do a Holter to rule these out, and then you treat the syncope with other conservative measures if you rule these out. So how do you test them? You always start with the basic easy ones to do, which is EKG and echocardiogram, and maybe a Holter. If it was exertional, then you do a treadmill. Tilt table is usually diagnostic, though it has a low sensitivity rate. If all that fails, you do an implantable loop recorder. So the key to tell the patient they cannot drive until the diagnosis is established and at least 3 months of no syncope before they start driving. Okay. Moving on, POTS syndrome, postural orthostatic tachycardia syndrome. So when heart rate goes up by at least 30 beats within a few minutes of standing up. We're seeing a lot of this as a side effect of COVID or long-term COVID symptoms. And this can make patients very uncomfortable. So it's a benign condition. So you could do beta blockers to decrease the heart rate. Sometimes they also drop their blood pressure. Then you do fluorocortisone or midodrine. But the first therapy would be, stockings, exercise, fluid intake, basically therapeutic lifestyle changes. So this is something you should know the criteria for diagnosis. So they could present a patient who stands up and the heart rate goes up by a certain number. What is your likely diagnosis? So that's how this is going to be worded. So other medications that are being used include Corlenor or ivabradine. SSRIs seem to help as well. So does pyridostigmine. But we don't use pyridostigmine because of a lot of side effects. Moving on to Hookham. It's the commonest cause. Well, right, currently it's the second commonest cause of sudden cardiac death in young athletes. The first is actually anomalous coronaries, but this is definitely up there in incidence. This will be basically some young athlete, school athlete or college athlete who has a murmur, and where you diagnose, either you have to diagnose the Hookham, or then they'll ask you, what does he do? If someone has Hookham with any kind of symptoms, they do not no longer participate in athletics until you do a complete workup. Just remember that. The other things to know is the severity of gradient does not correlate necessarily with sudden cardiac death. There's no cure for SCD other than a heart transplant. Now, if you do any kind of surgery to fix the hypertrophy, which you often do, either septal or surgical ablation, that does not decrease the risk of sudden death. So treatment for this first line is beta blockers, verapamil. Then there are certain criteria for ICD, especially risk of sudden death in either themselves or in a first degree family member, a massive hypertrophy, or if you find any VT on monitoring. I'm not sure they'll ask you this, but I think the first thing is definitely fair game. If there's a family member with Hookham and a sudden death, then the first degree family members do require ICD if they also have Hookham on echo. All right, moving on. I have about just about 20 more slides left. We'll go through that quick. So you know about CAD. I'm just giving you kind of the bullet points. Number one is primary prevention. So what do? They have asked this question several times over the years. So your first risk factor assessment starts at age 18, and you repeat it every 5 years. So you do basically screening and counseling and TLC, but you need to know the interval every 5 years after age 18. And then you do one of the risk assessment scores for men at age 35 and women at age 45. Role of aspirin in primary prevention, for both purposes, you almost never give it for primary prevention, all right? But I have a slide on telling you when to use it. But just remember this, every 5 years, age 18, and risk assessment at age 35 for men and 45 for women. That's fair game. Now, this is for secondary prevention. What are the medications that improve survival in patients with established ASCVD? 4 of them: beta blockers, ACE inhibitors, statins, and aspirin. So aspirin is good in secondary prevention. It's primary prevention that we have conflicting data. And sacubitril/valsartan has not been studied in ASCVD. It's only in CHF. So that's not the right answer here. Everything else that does not work, this is good to know as well. Hormone therapy, aspirin, primary prevention, vitamin E, folic acid, fish oil, None of these work in CAD. So moving on to symptoms, stable angina is anybody who's had chest pain for more than 2 months without any change in the character of the pain. So what do you do them? You said GDMT, guideline-directed medical therapy. What does that involve? You do aspirin. If they cannot tolerate aspirin, then you do clopidogrel, high-intensity statin, ACE inhibitors, and you could do beta blockers and nitrates for symptom relief. Now, revascularization is just for symptom relief. It does not in stable angina, PCI, or CABG does not increase survival. Of course, now remember Jardians, that's indicated in CAD as well. ACS, used to be unstable angina, now it's ACS. That includes everything from accelerating angina, unstable angina to non-STEMI. So here they call it high risk if the troponin is elevated. So if you have a non-STEMI or any EKG changes, then they need a cath within 24 hours. So not emergent within 30 minutes like with STEMI, but within 24 hours, 4 to 24 hours. And you treat them with aspirin, heparin, clopidogrel. These are all class 1 and beta blockers, as well as a statin. So remember that. ACE inhibitor, if they do have an MI, ACE inhibitors are important. They are, again, class 1 after an MI because they affect remodeling and improve the LV function long term. Oxygen, nitrates, morphine, none of those change the outcomes. So another question would be, someone calls you off as a chest pain. Remember, you tell them to call 911. They cannot drive. So there was a question where you tell them to drive to the ER because they live a mile away, or have them call 911. So you always make them call 911 only because they could have a sudden cardiac death. They could crash their car. So you don't want them driving. These people get EKG in the field. They also get aspirin by the EMT. Those are the first things you do. And in the ER, if you have someone with chest pain and the EKG looks okay, always remember to get leads 7 and 7, 8, 9, or the posterior leads. So if they're having a posterior MI circumflex territory, then that'll show up on those leads. So things to know about lytics. Again, we rarely ever use them. We only use them if they're in the middle of nowhere. So you got to give lytics only if the symptom onset was less than 6 hours. Remember that. The door to needle time has to be 30 minutes. Works better in anterior versus inferior MI, but you could use it in LBBB as well, new LBBB with chest pain or in ST elevation. You need to know the absolute contraindications. Any CNS hemorrhage ever, CVA less than 1 year, or any active bleeding, aortic dissection. PCI, door to balloon, less than 90 minutes. Remember that. Now, instead of door to balloon, it's become first medical contact to balloon. At least remember the 90-minute thing. To transfer, if total door to balloon time is less than 2 hours. So if you don't have a cath lab there, this is a very common question. You're in a rural ER, you have a person with chest pain. If the nearest cath lab is less than 2 hours, they can get to the lab within 2 hours, you transfer them, otherwise you do TPA. So 30 minutes for lytics, 90 minutes for door to balloon, and 2 hours if you're going to transfer them somewhere. So complication for MIs, I think we went over this in the last lecture 2 weeks ago. Right, RCA, tertiary infarct, think heart block, and RCR can also cause MR, but so can LAD tertiary. VSD is ventricular septal defect, and typically in anterior wall MIs. So acute death, acute tamponade would be free wall rupture. They could end up with pericarditis 2 to 3 days after MI, which is an immune-mediated mechanism. And of course, cardiogenic shock. These are the primary ones. You know all this. So we'll move on. So they're not going to ask you for CABG versus PCI, but typically diabetics with 3-vessel disease, you do CABG rather than multi-vessel PCI. The take home from this slide is PCI has a mortality benefit only in ACS or STEMI. As I said, in stable angina, it does not give you a mortality benefit. The other important things to know would be duration of antiplatelet therapy, Plavix or Prasurit, any of them you do. So this has changed. It used to be 1 year. Now, if it is minimum 3 months, if it's an elective PCI, but if the PCI was done in the setting of ACS, it's minimum 6 months. So you can stop, rather it's just 6 months. So you can stop it after 6 months. All bare metal stents are 3 months. So even if they had ACS, 3 months is 3 months at the ACS, 3 months is class 2A. So if they need to have a biopsy or any kind of surgical procedure, you could stop the drug antiplatelet therapy after 3 months. But otherwise, you continue for 6 months for ACS. It no longer needs to be 1 year for these patients. However, it is still, if you're just treating them medically, it's still class 1 to give Plavix for 1 year post ACS. Now, this is all for just stopping the Plavix. You still continue aspirin for at least a year, even if they're having surgery. So if someone wants to stop like spinal cord surgeries, they want to stop both aspirin and Plavix, they have to wait for 1 year. So things to remember with antiplatelet therapy. Brilinta, very common. More than 10% of patients have to stop it because of dyspnea. And with Brilinta, the other thing to remember is they can only take aspirin 81. In the initial studies with Brilinta, people who took 325 or 162 had worse outcomes. For whatever reason with Brilinta, if you do more than 81 aspirin, the Brilinta does not work. Things to remember with prasugrel, age more than 75, you do not give prasugrel. If they have a history of CVA, you do not do prasugrel. So those are the big contraindications. If they weigh less than 60 kilograms, you don't do prasugrel either for low BMI. Now, the other question would come up is triple therapy. If you have someone on a NOAC for AFib, then you usually just do the NOAC and either the Plavix or the Brilinta, whatever they are on, or you don't do aspirin. Just remember that we don't do triple therapy with NOACs anymore. We can skip this slide. So we have a few questions here. So here, basically, it's triaging patients. So would you do thrombolytics or PCI or conservative therapy followed by stress and CATs? The first one is a 50-year-old male with chest pain lasting anywhere from 30 minutes to 3-4 hours. It is unrelated to exertion, and EKG shows non-specific changes. So what would you do with this guy? Lytics, PCI, or conservative, rule out, and stress test?
Feel free to type your guys' answers in the chat too.
Yep, thank you. Someone answered stress test. So that's so basically this is classic, non-specific, low risk. Rule them out, do a stress test. Next one is a 50-year-old with jaw shoulder pain lasting 4 hours, pale diaphoretic. EKG shows a left bundle branch blocked. There's no previous EKG available. So what would you do with this person? Yeah, so this one would be classic CAT. It's a new onset LBBB with a good story. You CAT them. Next one is again a male with 4 hours of intermittent pain unrelated to exertion. EKG shows ST depression and T-wave inversion. So there's some non-specific STT changes. Correct. So this one, you don't have to CAT them right away, but this is the kind of person that you would, treat them medically and take them to the cath lab within 24 hours because of the significant EKG changes. That's good. Excellent. Last one, 4 hours of pain, radiating to back, diastolic murmur, unequal radial pulses. Yeah, this one would not, you probably need another choice for this, but CTA, correct. So this is probably a dissection, so you need to treat it as such, starting with the CTA. Excellent. Thank you. So moving on, valvular disorders. Really quick, starting with aortic stenosis. Indication for surgery or TAVR. Right now, these days, we do TAVR on everybody's symptoms. The reason being, once they become symptomatic, the survival goes down. It's angina. If they start having angina, median survival 5 years, and syncope 3 years. And if they have heart failure, just 2 years of median survival. And there's also high 10% risk of sudden death in symptomatic patients with AS. Almost all of them require a cardiac cath before you do the TAVR. So this slide has changed over the last 2 years. Earlier, we just did moderate high-risk candidates. Now, after the low-risk TAVR study came out, everybody gets a TAVR. So it's basically a heart team approach. That's a buzzword in cardiology these days. Everything is a team approach. So we send them to a valve clinic where the surgeons and the cardiologists look at them together and decide. Even in low-risk candidates, most of the time, if they don't need anything else done, then they just get a TAVR. So aortic stenosis is easy. Severe AS with symptoms, you do TAVR. If they are not symptomatic, you follow them. AI or aortic regurgitation, it's a little bit more complicated. So because they need to be symptomatic, and there are also echocardiographic criteria for this. So I don't think they'll drill you on that. Other things to know, if they have low gradients, so low flow, low gradient aortic stenosis, you do a dobutamine echo to increase the cardiac contractility and see if the gradients go up. If there's severe aortic stenosis by echo, but the patient says he's asymptomatic, then you make them walk on a treadmill to bring their symptoms out, and do a treadmill echo, and that way you could convince them that they need to have the valve fixed. So they're not going to ask you to choose between TAVR and SAVR surgical. So you just need to know what the indications are for fixing aortic valve. So bicuspid AV is the most common congenital cardiac anomaly. Right? 2% of all live births have bicuspid AS. The downside with this is you develop AS at an early age in your 40s. And about half of these patients have aortic aneurysms. So if you have a bicuspid valve, you want to make sure that you maze the aorta to make sure there are no aneurysms. Remember that. Moving on, mitral valve. MVP is very common. Depending on the criteria used on echocardiographic criteria, it can be up to 1 in 5. Mostly it's asymptomatic, it's benign. Some patients develop MR, and that's when you have to deal with it. So while MVP does not cause any symptoms, it is associated with a lot of vague complaints like chest pains and so forth. Mitral regurgitation, it's based on symptoms. Severe MR with symptoms, you operate, heart failure, so forth. But even without symptoms, there are echo-based LV dimension criteria that you don't need to know. The one thing to remember is that all regurgitations are volume and afterload dependent. So if the patient has serial echoes with severe MR in one echo and a moderate MR in the other echo, you always go with the worst regurgitation you've ever found in a patient as far as management is concerned. So mitral stenosis always pops up in the boards. Typically, it's from rheumatic fever. Usually a young woman with hemoptysis is typical presentation. So the good thing here is balloon valvoplasty is curative. So once you do that once, they're good for life. And pregnant women, remember, you do the valvoplasty in the 2nd trimester. That's the best time to do it because there's no the fetus is, there's a high risk of radiation injury to the fetus in the 1st trimester. And by the time the 3rd trimester, they really get terribly symptomatic. So you want to fix it before that. If they do have AFib, the only thing you could use for valvular AFib is still warfarin. Remember that valvular AFib is warfarin. Valvular AFib basically means more than moderate MR or any mitral stenosis. So pre-op evaluation, I'm kind of going to skip this because I think you guys are all pretty good with this. So infective endocarditis diagnostic test is TEE. The other thing to remember, if there's a pacemaker, you need to remove the pacer and the leads. So removing pacer is easy. Removing the leads is difficult, higher mortality, but you still have to remove them. Those are the current guidelines. So prophylaxis, you need to know who requires prophylaxis, right? Just 3 groups of people: prosthetic aortic valves, history of endocarditis, or complex cyanotic congenital heart disease. And any transplanted heart with abnormal walls, because these patients are immunosuppressed. So abnormal valves basically means mitral regurgitation, aortic stenosis, any kind of abnormality that's moderate or more in severity, they need to be prophylaxed. Now, what are the conditions where they require prophylaxis? As you know, routine colonoscopy, even GU procedures do not require prophylaxis. It's only more complex procedures where in dental procedures, if the gum is being exposed, if there's any incision involved, then you need it. With GI and GU, if they're going to disrupt the mucosa, with, let's say, dilatation, ERCP, anything complex, removing a polyp, those are the folks who need it. and you only need 1 dose pre-procedure, no post-procedure dose. And you typically start with the penicillin. So basically amoxicillin. If they're allergic to amoxicillin, then you use doxycycline or clindamycin. Those are the choices. So you can see images like this. The first one, this would be IV drug user or someone who's, clinically at risk of endocarditis. You see any of these spots, this is osseous node, Janeway lesion, and then rod spots in the retina. So think tricuspid endocarditis, lung abscess. Echocardiogram is the next test you would do. Cardiovascular diseases in cancer survivors. So the most common non-malignant cause of death in these folks is actually cardiac. So 25% of patients, Hodgkin survivors, end up with some kind of heart disease. And chemotherapy can cause, cardiomyopathy, heart failure. But the commonest one for you to know is constrictive pericarditis. This would be someone who was treated as a kid for Hodgkin's lymphoma. It's now coming in with symptoms suggestive of heart failure. Then think constrictive pericarditis. They might show you X-ray with a very calcified pericardium. Cardiac radiotoxicity. Basically, what I talked about here, this is moving on to pericardial injury. Acute pericarditis, about 20% of patients will develop chronic constrictive pericarditis. So acute viral pericarditis could end up in constriction, and up to 20%. That's a pretty good number. Just remember that. I'm going to skip a few of these. Oh yeah, acute pericarditis treatment. Most of them are idiopathic. As we talked about, post-amide restless syndrome. In renal failure patients, uremic pericarditis, and often up to more than 15-20% always have myocarditis. So if you check troponin in these people, a lot of them will have a low grade of myocarditis as well. So how do you treat them? Mainstay treatment, NSAIDs, high dose. Usually I use indomethacin. You could use ibuprofen. I do not use aspirin because the effective doses, you have a lot of GI side effects. So I prefer not to use aspirin. Colchicine, if you started, you got to use either BID or daily, but you got to use it for at least 3 months as initial therapy. If they fail these two and they have recurrences, that you could use corticosteroids. The downside to steroids is that when you taper them, they have recurrences. So that would be your last resort to use. Okay, moving on. I have a bunch of EKGs. That was my last slide in terms of didactics. So we can go over these. These are EKGs that have been shown in the boards in the past. So once if you can see this, these are fairly easy. You should be able to get it. Let's see who can get these EKGs. About 20, 25 of these. As you can see, you have a lot of P waves, more P waves than QRS. Perfect. So that's Venki-Bach. So what would you do to treat this? Right? Nothing. The postural dizziness has nothing to do with the rhythm. You don't do anything. So what's going on here? So as you can see, a lot of P waves here. It's tachycardia. QRS almost 150 beats per minute. So when you see a nerve complex tachycardia that's regular, it's some kind of SVT. And when you see these P waves here, that's kind of typically that look like flutter waves. So this was atrial flutter. So 21-year-old with seizures. What do you guys think? Perfect. So this is classic long QT. You see the long, this acute interval looks very long, very arch-shaped SC segment and T wave. So in this person, the seizure was probably VFib or VTAC, and she just survived. So 30-year-old African-American male with chest pain. Yeah, so this is, it could be early repolarization, but the PR segment do look depressed. So this would be, I would go with pericarditis here as well. So elderly with chest pain and dizziness.
Inferior wall MI.
Yeah, perfect. So that's inferior wall, classic inferior wall MI with heart block. So ESRD 60-year-old, what do you think is going on here? Yep, and the treatment here would be dialysis. All right, what's going on here? It's the same, actually it was the same person. It was actually a question. So that same person after a while goes into this rhythm. So this is not only heart block, you don't see much P waves, it's basically impending VTRS. So if you don't treat hyperkalemia, then they go into this wide QRS sino-atrial rhythm, followed by cardiac arrest. Good. So chest pain, what would you do next? Yep, so this is classic tombstoning appearance. It's a huge anterolateral infarct. So 21-year-old, someone with palpitations and syncope. What is your diagnosis? So a Brugada would typically, that's a good thought. A Brugada would typically have more of a right bundle branch block pattern and T-wave inversions. So this is more likely to be, you can see the little accessory pathway here. If you look
What
at
is WW? Actually,
yeah,
I was confused.
All
Delta
right.
wave with short PR.
That's right. So this is WPW. So if someone has syncope, the treatment would be at this point would be an ablation. So this person is probably going to rapid tachycardia. So what is the rhythm here? This one should be easy for you guys. So I'm sure you guys got this. This is basically just AFib, just irregular rhythm narrow complex. So what would you do next?
But Dr. Arasu, I think like there are P waves in the previous EKG, right? So I thought we don't call it AFib if there are some P waves.
So you have to, yeah. So typically for not calling it AFib, you need to have organized and regular P wave activity. So you see a few P waves. This is coarse AFib. So like for example, you see something here. This could be probably a T wave, but you cannot march anything out.
Okay.
So that's the reason this is AFib, and there's no really discernible pattern to it. QRS complexes are kind of all over the place. I do have a slide. I think EKG of MAT. I'll show that to you next. Okay. So what would you do next?
It's torsades.
So yeah, it's so you can see at least in the this was actually monomorphic because you don't see a definitive change in the axis. They all look the same way. There's some difference in lead 2, but mostly. But what you do next to either case would be a shock, right? That's what we were looking for. Chest pain and dyspnea. So this is basically classic left bundle branch block. So someone comes with the new onset chest pain and left bundle. That's what this was meant to be. All right, show you guys. Okay, here we go. Now this is what you now this is what torsades would look like, because you can see the axis going going up and down. And the treatment for this is shock. And then what else do you do for torsades?
Magnesium.
That's right, magnesium, and at least 2 grams to start with.
I have a question to the previous one, the left bundle branch block patient, acute. So that would be, the patient will be sent to the cath lab too?
Yes. So if no previous EKG, if it's a new left bundle with chest pain, then you got to presume there's MI that's hiding there. So you got to treat it as as ACS, send them to the lab. All right, thank you. So this was another question. What is the EKG showing there? What's the rhythm? So in this one, there's no P wave activity. This is probably AFib, and this is classic. You know, it's like a tick mark pattern here. This is classic digoxin. Effect on EKG. This by itself, the ST segment change itself is okay, but this person, the QRS looks very regular. It's very slow. So this would be dig toxicity, and so you would stop the digoxin here. Okay. It's a 50-year-old found unconscious. This is the EKG. What do you think is going on? So the main abnormality here, as you can see, are obviously the T waves. So you have kind of deep symmetrical T wave inversion throughout. So this is classically seen in strokes, any kind of sudden change in intracranial pressure. So hemorrhage, intracranial hemorrhage, and stroke. Okay. Okay. 38-year-old just had knee surgery recently. Now is suddenly short of breath.
Right heart strain with the spine skewed right pattern.
Yep, perfect. So that's, you can see big, fairly big R wave in V2, V3, tachycardia. There's S1, Q3, T3. So this is classic for PE. Good. Okay, 90-year-old with dizziness. What would you do next?
Complete.
Yeah, I think that's complete heart block. You do, you do a pacemaker. Even if
Pacemaker.
you're not, even if you're not sure it's bradycardic, even if you think maybe it's Menkibach and you're trying to do your calculations, but someone with symptomatic bradycardia like this and some kind of AV block, you would still do a pacemaker. All right. So 30-year-old, really dizzy, let's say hypotensive, what would you do?
Vagal maneuvers.
Yep, right, vagal maneuver. So the choices would be you try something vagal, then you could do adenosine. If that doesn't work, they're hypotensive, then you shock them to convert them back. All right, good. So this was just, as you can see, just for prolonged first degree AV block. No matter how big the AV, if it's first degree, no matter how big the PR interval is, you don't do anything, especially if they're asymptomatic routine EKG. That's what this was supposed to show. Okay, severe COPD. What do you think?
Matt.
Yep, perfect. So now here you see good, nice, organized P wave, even though it's completely irregular, but you see really discrete P wave before QRS complex, every QRS. So this is typical MAT. Should have at least 3 different morphologies, which this does have. All right. This is just an asymptomatic African-American male, just routine EKG. What do you think? So this is basically to demonstrate early repolarization. You can see V4, 5, 6, how the ST segment appears elevated. So if they're asymptomatic, now if they have chest pain, then you got to figure out, make sure that this is not pericarditis. But if they're asymptomatic and you see something like this, then it's normal, just early repolarization. Here, the PR segments, you always compare the PR segments to the previous TP segment. For the previous beat, and compared to that, there's no PR segment depression. It's at the same level. So this is this is the classic early repolarization, again a normal finding.
Sorry, I got a question to the previous one.
Sure.
I didn't know how to recognize the early repolarization again. Sorry. What are the criteria?
So the early repolarization is basically pattern recognition. So it'll be like a smiley face, U-shaped ST segment. I think there's another more classic EKG coming up. So if you see a ST elevation that's U-shaped, or what, just remember smiley face, it's normal, and there's no PR segment depression. There are no reciprocal changes. So early repolarization is a combination of EKG as well as clinical presentation. So someone with the early repolarization, if they come in with chest pain, then you still have to, manage them as though the EKG is not early repolarized, as though it's pathologic, and you got to treat them appropriately if they do not, especially if they don't have a previous EKG. But if it's asymptomatic and you just see ST segment elevation that's U-shaped, then it would be consistent, and there are no other reciprocal changes, no ST depression, other leads, then it would be early repolarization.
Okay, thank you.
Yeah. So, what do you think is going on here? Chest pain, smoker, multiple risk factors.
Looks like both anterior and inferior.
So when you have ST elevation in multiple leads, then so for example, if you pay attention to V2, you can see that the PR segment is lower than the previous TP segment, and even in V3. So this would be pericarditis. If you did not look at if you don't look at the PR segment, if you just look at the QRS alone, you could, this is basically what early repolarization would look like. So for you guys, for most EKGs for the boards, they will give you a good snippet, a good clinical history as well. So that'll help you kind of guide you one way or the other. So this is classic pericarditis. So 85-year-old, no meds. What do you think the rhythm is here? Asymptomatic.
Easy block, 30 degrees.
Yeah, so well, in this case, the PR is matching. This is clear. It's 2:1 AV block. So it's Mobit's, it's second degree AV block, but we don't know if it's 1 or 2 because it's just 2:1. You couldn't say it's Venki-Bach or if it's Mobit's 2.
Yeah, that's why I'm confused. I think this, how to differentiate whether it's 1 or 2, doctor?
So in this case, we just call it a 2:1 AV block.
Okay.
All right. So then what do you do next? That would be the question. So what you do in this case is next is you test them for chronotropic competence. So you make them exercise. And as they exercise and the heart rate gets higher, then the block will change. Then you determine if they can increase their heart rate by at least 10 beats per minute with some activity, and without the block being without it worsening, then you don't have to do anything. You could conservatively treat them. If they do not have chronotropic competence, or if the block, as they increase the heart rate, the block will reveal itself. It'll either be a Venki-Bach, it'll become 1:1 conduction, or it'll worsen. If they have a true second degree Mobitz 2, then the block will worsen with exercise. So for board purposes, the next thing you do here would be a chronotropic competence test. Test them, make them walk, or do some exercise. All right. Okay, yep. So the EKG will be associated with what arrhythmia? Well, basically, someone with this EKG will be more vulnerable to what kind of arrhythmia? So it's basically prolonged QT interval here. So they'll in the board exam, they will give you the QT interval for this EKG, so you know what it is. So you just have, yeah, that would be the answer. All right. Okay. All right. So a few more questions. This is probably in the past I had these collected from the residents giving me the questions after they took the boards. It's probably illegal, but anyway, here we go. So first one, these are actual questions, so let's breeze through them. So history of lung cancer, hypoxia, EKG shows S1Q3T3. So here, Yeah, P. So here they just show the EKG. I'm just giving the interpretation. So I'm sure you guys can recognize that. So it's a murmur that worsens with Valsalva and decreases with hand grip.
HOCM.
That perfect. All right. Young woman with palpitations, EKG shows AVNRT. What would you do next?
Adenosine.
Carotid.
Yeah. Even yes. So the answer is adenosine, vagal maneuver, adenosine, and ablation. Those are the three things. Next one, I give you the answer to. A patient had yellow vision, complaint of yellow vision, has Venki-Bach on EKG, has nausea, vomiting. So that's stop ditch toxicity. Yellow vision, ditch toxicity. All right. So acute MI, cath lab 3 hours away. What do you do? So you do TPA, right? What's the cutoff for transferring patients?
90 minutes, 2 hours. 2 hours is
that's it. Correct. Excellent. 2 hours for transfers. 90 minutes is door to balloon time in the same institution. Okay, so the answer was supposed to show up later, but when I transferred from my Mac to the Windows, it's showing up together. The animation is gone. But anyway, so someone with amaurosis fugax, cholesterol emboli, so TIA, any of these conditions, what is the first test you would do? It would be a carotid Doppler. Then there was Swan-Ganz waveform showing various things. I think in this board, there was a PA pressure waveform. So we went over that the last time. You should know what that looks like. Someone with Hodgkin's radiation constriction, we went through that. So reverse split S2. So they'll give you basically a stem basically said on the physical exam, there's a reverse split of the S2. So answer is left bundle. So this is basically some of the other things that come over, which we went through. I think that was the last slide. Thank you, guys. Do you have any questions at all? All right, then. I know it's been a long evening. Thank you all for joining. All right. Take care now.
Very much.
Yeah. Bye-bye.
We appreciate it.
Thank you.